Morning, everyone. I'm Dr. Mohit Chaudhary, and I'm accompanied with me, Dr. Rashmi Jain, who is part of this TransConnect, and we'll be talking on RH incompatibility, fetomaternal hemorrhage, and RH immunoglobulin prophylaxis. This is March 2023, and this is the topic that we have chosen, which is actually a sore point for a lot of PGs who are trying to master this topic. So we'll be talking about RH incompatibility per se, what fetomaternal hemorrhage is, how to calculate the RH immunoglobulin dose, what is KB test, what is the Rosette test, how we do flow cytometry for these, and where all we do this prophylaxis. So our learning objective will be RH incompatibility, anti-D immunoglobulin, current consensus on anti-D prophylaxis. We'll be covering some part of the BSCH guidelines and the assessment of fetomaternal hemorrhage, which method we should do, how we should do the screening, followed by the KB test, followed by the flow cytometry if we have that available with us. So coming to RH incompatibility, I would call upon my colleague Dr. Rashmi to take from here.
Very good morning to all. I will be talking about RH incompatibility and how to approach a case with the RH negative pregnancy. Let's understand what is this RH system. RH system includes 5 erythrocyte antigens, which includes capital C, small c, capital D, capital E, and small e. Point to be noted, there is nothing called small d. All these erythrocyte antigens are present on the short arm of chromosome number 1. These antigens do not appear on other tissues or any body fluids. What do we mean by D negativity? D negativity is defined as the absence of D antigen. It's very important that we understand this point because if an individual who is lacking a specific erythrocyte antigen, he may produce the antibodies against it when being exposed to that antigen. And this concept is being experienced during the Rh negative pregnancy, wherein the maternal antibodies with the Rh negative status, they can produce they can cross the placenta and colonize the fetal cells which contain the associated antigens and hence can result in the hemolytic disease of fetus and newborn. D antigen, if we see overall, it is a highly immunogenic antigen such that exposure to less than 0.1 ml of positive RBCs can stimulate antibody in an Rh negative person. Incidence of Rh dealuminization in D negative women following the deliveries of D positive ABO compatible infants was approximately noted to be 16%, and initial and days back HDFN due to anti-D was the significant noted cause of morbidity and mortality. However, with the practice of routine postpartum administration of anti-D RhIG immunoglobulin has dropped the rate of illuminization to approximately 2%, and further reduction was noted in the sensitization rate ranging from 0.17 to 0.28% with the introduction of the routine practice of antenatal prophylaxis during the third trimester of pregnancy. Now, let us understand what happens in the Rh negative pregnancy. Let us see the pathophysiology of Rh negative pregnancy. In this it begins with the first pregnancy, wherein during the first pregnancy, if there is any potential sensitizing event which results in the fetomaternal hemorrhage, there then there is the hemorrhage of the D positive fetal RBCs into the D negative mother, and as a result the mother antibodies are being formed against the paternally inherited D antigen, and this will have consequences on the next D positive pregnancy as these are going to pass through the placental passage and of the maternal IgG anti-D, and these maternal antibodies will attach to the fetal RBCs and it will cause the hemolysis of fetal RBCs and resulting in the hemolytic disease of the fetus and newborn. Let us see how these blood group systems are affiliated with the clinical severity of HDFN. As we all can appreciate over here, it ranges with the mild, moderate and severe. Mild to moderate is being caused by RH. capital E antigen and small e antigen. And on the other side, moderate to severe is being caused by Rh capital D, capital C, and capital C, and small c. Now, this is how the are the signs and symptoms which we are going to see in case of the hemolytic disease of fetus, newborn and fetus. First, it comprises of if we see into the main features, it includes the anemia and jaundice. These are the main findings which are going to be appreciated. It is appreciated in the two stages, early onset anemia, or there could be late phase, which could comprise of the hemolytic anemia or late hyporegenerative anemia. The early onset anemia is being noted within the 7 days of the birth, and the mechanism is antibody mediated hemolysis, and it can be seen that bilirubin levels are being raised, and the retic count in the newborn will be normal to high. On the other hand, in case of the late hemolytic anemia, it is more than 2 weeks of age can be encountered. It is in the mechanism includes three, which is antibody mediated hemolysis. There could be natural decline of the hemoglobin levels and expanding intravascular volume of the growing infant. In such cases, bilirubin level is usually high with the normal to high retic count. In the last one, late hyporegenerative anemia, which can be encountered after more than 2 weeks of the birth. Then it is also an antibody destruction of RBC precursors and RBCs, and there could be marrow suppression by the intrauterine transfusions, and there could be a erythropoietin deficiency, expanding intravascular volume of growing infant. In such cases, by this time the bilirubin can normalize, and there could be a fall or there could be absent retic count. Now, let us understand how we should approach to a case of Rh negative pregnancy. So, whenever a pregnant female is approaching for the antenatal care, whether it's a book case or first antenatal visit, we should firstly determine the Rh status of that pregnant female. If Rh negative is there, then we should determine the Rh status of her husband. Let's see what all possibility is there. If husband is Rh negative, then we do not need to do any further workup. However, if we find out that the husband is Rh positive, then we need to take further call, right? We need to regard this pregnancy as a Rh negative pregnancy, and such pregnancy is being categorized as a high risk pregnancy and requires a very close monitoring and further workup. So we are going to plan a test called indirect Coombs test. Now, let us there could be a possibility that this test can come positive or negative. What happens if ICT is going to come positive? It, it states that if ICT is positive, that means it is a sensitized pregnancy. That means antibody formation has been there, and therefore there is no role of administering the antepartum Rh immunoglobulin for protecting. However, when it comes negative ICT, then what do we understand by negative ICT? That means the pregnancy is unsensitized. No, yet the antibodies are not being formed. Therefore, in such cases, there will be a protective role which will be offered by the routine administration of the anti-RhIG immunoglobulin, and further after the delivery, postpartum anti-D prophylaxis in adjunct with the FMH dose adjusted can be administered. Now let us discuss in great detail how to approach a case if ICT is being reported positive. In such cases, we are going to repeat the maternal IgG antibody titer every 4 weeks till 24 weeks, and thereafter we are going to see whether we have achieved the critical titer or not. The critical titer has been identified as 1.61 is to 16. So if this titer is achieved, what we are supposed to do? Then we will not monitor the titer further, rather we will shift our rather we are going to monitor the fetal growth more meticulously. We are going to do the serial middle cerebral artery peak systolic volume velocity Doppler every week. Now what happens if the titer is less than 1 is to 16? Then if the titer is not rising, then we are going to check it 2 weekly till the term, along with the meticulous fetal surveillance, and the fetus should be delivered by 37 to 38 weeks. Now let us take a great look let us take a great look at the middle cerebral artery peak systolic volume Doppler findings, because the further course of management in such cases is important to understand. See, if if MCA-PSV Doppler is reported to be less than 1.5 medians of multiples of median, then what we are supposed to do? We are going to repeat it weekly along with the close fetal surveillance from 32 weeks onwards, and the baby should be delivered by 37 to 38 weeks. However, if this value MCA-PSV Doppler is more than 1.5 MOM, then we are going to see what is the period of gestation. Whether it is more than 35 weeks, then we are going to deliver, and with the process with along with the delayed cord clamping. Already that means the fetus is in anemic state, so delayed cord clamping will somewhat help to raise the hematocrit of the fetus. However, if the period of gestation is less than 35 weeks, then what we are supposed to do? We have to plan the intrauterine transfusion, right? It should be repeated for every 10 to 14 days, and then fetus to be delivered by 37 to 38 weeks. Now, what to do in cases where ICT is being regarded negative? Then we are supposed to repeat the ICT at 28 to 38 weeks. And if in between that any potentially sensitizing events occur, potentially sensitizing events like any sort of maternal bleeding, mother is experiencing bleeding, or any sort of invasive procedure she is undergone which is posing her at the risk of fetomaternal hemorrhage, then in such cases we should administer the RH immunoglobulin within 72 hours of that event. One dose has to be administered, which is equivalent to 300 micrograms or 1500 international units. However, if ICT still comes negative, then in such cases, and there are no potentially sensitizing events prior to the antenatal period, then by 28 weeks, we are supposed to administer the routine antepartum anti-D prophylaxis, which is about 300 micrograms, right? And we are going to deliver it at term, and in this we will prefer the early cord clamping in order to prevent the sensitization during the delivery. It is very important to take note in between the after administration of antepartum anti-D prophylaxis at 28 weeks and within a span of 25 days, if any potentially sensitizing events happen to occur, then no repeat dosage should be administered to mother. Now let us see what dose should be administered at postpartumly. So in this condition, we are going to give the dose in titration with the feto-maternal hemorrhage, and it should be administered within 72 hours of delivery if RH status of the newborn is positive, and irrespective of the findings of the DCT result. When the baby is born, we are supposed to perform a DCT. However, that DCT result can be reported as positive in certain cases. Even despite of being reported as positive, we should administer the antepartum prophylaxis of RH immunoglobulin. It is very important that we understand what is the aim of this administration, because we want to protect the subsequent pregnancy. FMH, now the dosage is very important to be understood. So one vial has to be administered postpartumly, and we are going to conduct the post feto-maternal hemorrhage screen, which comprises of two tests, that is Rosette test. It is a qualitative test to determine the feto-maternal hemorrhage, and the quantitative test, that is the Clear-Betke test, which is being conducted within 2 hours of delivery. So if FMH screen is being irrespective of FMH screen coming positive or negative, that is Rosette test being reported positive or negative, we are supposed to administer the one vial of RH immunoglobulin. However, if Rosette test is being reported as positive, we have to make a further workup. We need to perform KB test, that is clear bed kit test, and we need to quantify the fetal, and we need to quantify how much fetomaternal hemorrhages happen to occur. So we will be discussing how to calculate the dosage in a short while in subsequent slides. One important point to be noted that after performing the KB test, if the FMH is more than 4 ml, then we need to conduct flow cytometry if it is available in your center. So to calculate the exact dosage of the RH immunoglobulin. So now let us see what is Rh immunoglobulin. It is a concentrate of predominantly IgG NTD which is being developed from the pools of human plasma. It is being available in two doses, 300 micrograms which is equivalent to 1500 international units, and this is being sufficient to counteract the 15 ml of D positive pegged red cells, or what we call as, or 30 ml of the whole blood. The other dose which is available, that is the mini dose, is the 50 micrograms. This is being sufficient for 2.5 ml of D positive blood. However, it is not being used much. So let us see how does it act. That is mechanism of action of Rh immunoglobulin. So this is going to prevent the mother from making the immune anti-D by suppressing the immune response. And if we see the antibody structure, then it is going to saturate the placental Fc receptors, which will further inhibit the maternal antibody transfer. RhIG is going to attach to the Rh plus fetal RBCs, and it will activate the suppressor T cells, and further, in a nutshell, it is going to act as an anti-iotype antibody. Now let us see what are the indications and various dosage of Rh immunoglobulin. So indication 1, if the pregnancy is being terminated with before 12 weeks of gestation, then we can administer 50 micrograms IM. If it is being terminated more than or equivalent to 12 weeks, then it can be administered 300 micrograms, that is one vial needs to be administered intramuscularly or by intravenous routes. Other invasive procedures, are being done, that is less than 34 weeks, then we can administer 300 microgram dose either IM or by IV route. It should be noted that it needs to be repeated at 12-week intervals until the delivery. If any invasive procedure is being performed beyond or equivalent to 34 weeks, then also we need to administer one vial of Rh immunoglobulin, that is 300 microgram dose, either via IM route or IV route. If the patient is having any sort of obstetric complications are being there, then also 300 micrograms of Rh immunoglobulin needs to be administered either by IM route or IV route. As discussed priorly, antepartum at 28 weeks of gestation, we need to administer the 300 micrograms of Rh immunoglobulin either by IM or IV route. And postpartumly, as just now discussed, the dose has to be titrated in conjunct to the fetomaternal hemorrhage. However, one vial has to be administered. It could be either administered by IM route, intramuscularly or intravenously. And last but not the least, if there is transfusion of any Rh positive blood, then we need to the dosage has to be 20 micrograms per ml of RBC either via IM route or 18 micrograms per ml of RBC via IV route. Now, what are the contraindications of Rh immunoglobulin? So, FDA has labeled the contraindications and it vary by manufacturer, but these include the following. If any hemolytic reaction is being noted after if administered to a Rh positive patients, then it is contraindicated to administer in such patients. If the patient is presenting with a history of severe hypersensitivity or any sort of anaphylaxis to any human immunoglobulin product, then also it should be not administered. Then if in certain manufacturing products, they may contain small amount of IgA, and therefore in IgA deficient individuals with having the antibodies against the IgA, it should be strictly avoided. Now let us take a great look at whatever brands are available in India. So these are the following brands which are being available. It's a Rogam Immunoro with a strength of 300 micrograms, Vinobulin 100 micrograms, Resumin in a 300 micrograms available as 2 ml vial. Roglone is there. Roglone is available in two strengths, 150 microgram, 300 micrograms. Metagam P is there, 300 micrograms. Now, my colleague Dr. Mohit Chaudhary will be continuing and discussing how to assess the fetomaternal hemorrhage in Rh negative pregnancy. This is very important from a practical point of view. Now, my colleague will continue forward.
Hello everyone. In the last topic, we had covered about the Rh immunoglobulin, the routine anti-D prophylaxis, about fetomaternal hemorrhage, and the algorithm involved in it. In this episode, we'll be calculating the dose of RhIG, what we need to give, what are the methods to detect fetomaternal hemorrhage, and how we go about actually, in practical, which test to employ when do we do a flow cytometry, when do we do a Rosette test, or when do we do a quantitative test like KB test. So I'm Dr. Mohit Chaudhary and I'll be taking you through this lecture on calculation of RhIG dose. This is TransConnect, March 2023. So let's start with this very important topic, a small topic, but I think it should cover all your doubts about the calculation of RhIG dose. It looks a little difficult, but if you just go through the lecture once, I think you'll be able to solve this problem of RhIG dose. So what are the methods for detection of FMH? The methods are qualitative methods and quantitative methods. The qualitative methods, we categorically do the Rosette test. This is a test that will tell you whether it is positive or negative. So if it is positive, that means there is an FMH, and if it is a negative test, that means there is no FMH and you don't need to go further with the KB test. However, whether your Rosette test comes positive or negative, you still have to give one full vial of Rh immunoglobulin, that is 300 microgram. That needs to be done irrespective of whether it comes positive or negative. Once it comes positive, obviously you'll move to a test like KB test. Of course, you can do another quantitative test, and which is very sensitive and very good, is flow cytometry, but provided you have that in your institution. What is a Rosette test? It is a screening test to detect the presence of Rh positive RBCs in the circulation of Rh negative person. It is a qualitative test, that means yes, no test. It will tell you whether the fetomaternal hemorrhage is present or not present. And the procedure involves the anti-D is added to the mother's washed RBCs. It is incubated, washed, and then added within R2 indicator cells. The rosette formation takes place, and if the specimen is giving positive result, there will be a rosette formation. Once that comes positive, you go for the KB test or Clay-Hall-Becker test. It is basically involves, the principle involved in this is that hemoglobin F, which is present in the fetus, is resistant to the RBC's elution. So whenever you add an acid elution, it will be resistant to it. However, the normal HbA or the adult cells will actually lyse. So you will have normal cells from mother that are adult cells that will lyse, will look like ghost cells, whereas HbF cells which are resistant or resilient to this acid elution, and they will shine bright red. So this is how it will look like. You can see this bright red color. These are the fetal RBCs, and in the background, these silhouette that you can see of the RBCs, these are called as ghost cells. Another picture of the same. So KB test here demonstrate massive fetomaternal hemorrhage after acid elution treatment. Fetal cells rich in HbF stain darkly, whereas mother cells or the HbA cells are like ghost cells. Coming to the main part of the topic, that is calculation of amount of Rh immunoglobulin from the KB test. It is very simple. You just need to go through this once, and with the examples try to calculate your own dose, and I think that should be it. So what you need to do is you need to count 2000 cells in the microscope after you have done the KB staining. So once you have that, you have 2000 cells. So you calculate the number of fetal cells, note it down like you do in a cell counter, you note it down. You calculate the total blood volume of the mother. Suppose the weight of the mother is not there, you can calculate it as, or you can take it or presume it as 5 liters. So first thing you need to do is calculate the percentage of fetal hemorrhage. So how you do that? It is very simple. Total number of fetal cells counted upon total cells counted into 100. That is, suppose it is 40 fetal cells out of 2000 cells that you have counted, multiplied by 100, you get a percentage, and that percentage is 2% here. Once you have the percentage, you have to know actual total fetomaternal hemorrhage. What is that hemorrhage, or what is the hemorrhage in ml that has taken place? So it is very simple. You know the total volume of the total blood volume of the mother, that is 5 liter presumably. So you can multiply it by the fetal hemorrhage. So for example, if the fetal hemorrhage percentage was 2%, you multiply it by 5000 divided by 100, which will give you 100 ml. So that is the amount of fetal hemorrhage in ml. Now the main part of the exercise, how to calculate the RhIG vials. It is very simple. We should know that one vial of 300 microgram, that is the full dose of the vial, will cover 30 ml of fetal whole blood. That means one vial will cover 30 ml. So suppose your total hemorrhage was 100 ml, and you know one vial covers 30 ml, you divide the same, you will get this decimal, a decimal value, that is 3.3 or 3.2 or anything like that. So this is the actual value on which now you will calculate the RhIG values. It is very simple. You don't want to deal in decimals, you round it off. So suppose it is 3.3, it rounds off to 3. It is 3.6, it will round off to 4. Here it is 3.3. So once it is 3.3, you round it off to 3 and add one vial to it. And why do you add this one vial? It is very simple. You are adding this vial categorically because this KB test is not very accurate, so you want to overdo it. So suppose it is 3, you add one vial to it. Suppose it is 4, you add one vial to it, it will become 5. Another example, suppose there is fetal cells in the mother is 26, here it is 26. So what is the percentage? It is 1.3, 26 upon 2000 into 100. Remember, you always calculate 2000 cells. So 100 ml mother blood will carry 1.3 ml. So by unitary method, you can calculate in 5 liter of total blood volume, that is mother's total blood volume, it will be 65. You just divide 65 by 30 because that is the amount of blood one vial will cover or neutralize. So it will be 2.2. So now it is again 2.2, you round off, simple maths, 2.2 becomes 2 and add one vial to it, and that is the total number of vials that you need. So total number of vials that you need here is 3. Remember, if your Rosette test is negative, that means even if you are anticipating there is no FMH, you still have to give one vial. So that means either you will give the minimum is one vial, or you will calculate the FMH and then calculate the number of vials. Always remember, always remember, the half-life of this RH immunoglobulin is 25 days. So you need to remember that. So calculation of RhIG safe dosage, it is the same thing. Suppose the dose that you have calculated or the decimal value that you have calculated is 2.2, you add 1 to it, 3. Suppose it is 2.6, it becomes 3, and you add 1 to it, it becomes 4. So there's another method that you can do, quantitative method for fetal maternal hemorrhage estimation. It is the most sensitive of all methods. This is flow cytometry. It correctly quantifies FMH. It uses the human monoclonal anti-D and murine monoclonal anti-HbF. Many advanced centers have replaced it with from the KB test. But if you can't do it, KB test is fairly accurate. And how do you make it more accurate is you add one more vial to it. So BCSH guidelines also says that perform flow cytometry if your FMH or your KBT test or the KHR blood K test is greater than 4 ml. Other methods for estimation are under evaluation like gel agglutination test and maternal AFP. So we are still a long way to standardize these tests. Till then, you should know how to do a KB test and a flow cytometry test. Thank you so much. I hope this simple topic of calculating the RH immunoglobulin dose was helpful to you. If there is anything that you have not understood or you want me to repeat it, you can just write a comment on this channel and we will try to address the same. Thank you so much. Keep on learning and keep telling us which topics we should take up next. Happy learning to all of you.